Younger adults diagnosed with cancer are uniquely vulnerable to financial strain due to disruptions in employment, education, and limited access to income protection measures. These challenges often coincide with a life stage that is marked by economic instability and limited financial literacy, amplifying the impact of these treatment-related costs. Despite growing recognition of its influence on care adherence, mental health, overall well-being, the financial burden of cancer remains insufficiently addressed in standard oncology care. Embedding financial counseling and resource navigation into the cancer care continuum is critical to alleviating hardship, improving patient outcomes, and also supporting long-term survivorship planning. So this panel discussion, Managing the Cost of Cancer, Financial Navigation for Early Age Onset Cancer Patients, will be moderated by Stephen Piazza, Director of Advocacy with the Canadian Cancer Society. Stephen is joined by Chantal Thurston, who will be wearing multiple hats in this discussion, sharing her perspectives as an appendix cancer survivor, combined with her professional expertise as a CPA and the board chair of EAOC. We also welcome Meg Pfeiffer, psychosocial oncology clinician with Cancer Care Manitoba, Mary Stewart, family nurse practitioner at the AYA Pediatric Cancer Survivorship Program at IWK in Halifax, and Shannon Lee Simmons, award-winning certified financial planner, best-selling author, and personal finance writer. So welcome, panelists. And Stephen, I'll pass it right over to you.
Perfect. Thank you so much. And good afternoon, everyone. And thank you for being here for this important conversation. As Cassandra mentioned, we're talking about something that touches every part of the cancer experience, not just treatment and recovery, but the financial realities that come with it, the cost of cancer care in Canada. Cancer remains one of the leading causes of illness and death in this country. Its impact on our healthcare system is profound, and its impact on people, in terms of physical, emotional, and financial tolls, often feels immeasurable. This sentiment was expressed by one of our patient partners, who said, "The physical, emotional, and financial toll of cancer often feels beyond measure, but patients, survivors, and caregivers know all too well that the financial burden is real, and so we must measure it, because what cancer costs us, as individuals and as society, matter." At the Canadian Cancer Society, through our collaboration with the Canadian Cancer Statistics Advisory Committee, Statistics Canada, and the Public Health Agency of Canada, we publish the Canadian Cancer Statistics Report. Every second year, we release a special report on a topic of particular relevance to the cancer control community and Canadians at large. Last year, that topic was the economic impact of cancer. And here's what we found. In 2024, the total cost of cancer to Canadian society is projected to be $37.7 billion. About 80% of that, or $30.2 billion, is borne by our healthcare system. But the remaining 20%, roughly $7.5 billion, falls directly on individuals with cancer and caregivers. And that number is increasing. We expect it to increase to $8.8 billion over the next decade. In fact, cancer costs the average patient nearly $33,000 over the course of their lifetime. The majority of that is direct out-of-pocket costs, but this figure also includes lost time and lost income from receiving care. And the bulk of these costs for patients and their families are in the first 12 months of treatment. So once we launched our report and socialized it publicly, we partnered with the Angus Reid Institute to understand how Canadians perceive these costs. We polled over 2,000 Canadian adults in January 2025 through the Angus Reid Forum, and the results were striking. Among working-age Canadians, 80% said they would struggle to save a retirement if faced with the cost of a cancer diagnosis. 2/3 expected they would need significant unpaid time off work, and 42% worry they would miss an opportunity for career advancement. Among those who have experienced cancer firsthand, 40% reported struggling to save. 1 in 5 said it was difficult to pay their monthly household expenses, and nearly 1 in 4 said it was hard to make payments on non-mortgage debt. Essentially, working-age Canadians, on average, are forced to take from their future to pay for their present of a cancer diagnosis. Finally, we asked Canadians who should bear the main responsibility for costs that aren't currently covered. The majority said government, either provincial or federal. This was followed by 1 in 5 who said private insurance should do more. And fewer than 1 in 10 believed it should fall on individuals themselves. And this really reflects a shared belief that no one should be financially burdened simply because they were diagnosed with cancer. So, as we begin today's discussion, let's keep in mind cancer is both a health and an economic challenge. And we know that it doesn't impact everyone equally. With our panel, we're going to touch on the realities faced in early onset cancer and how we can work together as patients, health, and interdisciplinary professionals, advocacy organizations, and industry to fill these gaps. Through this session, we're going to examine the drivers of the financial burden among early age onset cancer, identify approaches to strengthen the financial literacy and self-advocacy, and finally outline rights-based protections and policy gaps that can be strengthened to help solve a lot of these challenges. Before we dive into this broader discussion, I'd like to start with Chantel. Chantel, as Cassandra said, you're wearing multiple hats on this panel. But can you tell us about your experience with the financial side of cancer care, maybe as a patient, and help us understand what these challenges look like to the lives of patients and caregivers themselves?
Thanks, Stephen. I sure can. I can speak to a lot of what you were saying. My name is Chantel Thurston, and today I want to share my cancer story, and not just the medical details, but the real life impact that goes unseen. I was diagnosed at 34 with stage 4 appendix cancer, and overnight, everything in my life shifted. Within 2 weeks of hearing the words, "You have cancer," I had to leave work. I used up my sick time and then moved on to employment insurance for the first 4 months, and eventually had to apply for long-term disability. In total, I was off work for 18 months while going through treatment and recovering. My husband naturally wanted to be there to support me, but his workplace wouldn't allow him to use sick time to care for a spouse. So he had to take unpaid days, which added another layer of financial strain. There is Canadian EI caregiver benefit, but it can only be accessed if the person you're caring for is expected to die within 6 months. That criteria alone is devastating, and even then, the application process is complicated and slow. So we navigated most of my treatment period without support. Financially, we were lucky to have savings and family support. Not everyone does, especially new immigrants to the country. Many patients struggle to meet basic needs like housing and groceries, and even with public health care, the out-of-pocket costs add up quickly. Parking fees at hospitals and clinics, medications not administered in hospital, and other unexpected expenses. We were also fortunate that our families lived close by. At the time of my surgery, our son was 3 years old, and I was his primary caregiver. During treatment weeks, my 12-day hospital stay, and the long recovery afterward, I simply couldn't take care of him. Our family stepped in with childcare, meals, laundry, and practical support, and we were able to hire help for cleaning. Without that, my husband would have likely had to take extended time off or even leave his job entirely, and we would have been in real trouble. The emotional cost was heavy too. I had to self-advocate constantly. I saw at least 4 doctors over a couple years and ultimately received a delayed diagnosis of stage 4 appendix cancer. Delayed diagnosis has consequences, not just medically by having a larger surgery and more chemotherapy, but financially, professionally, and emotionally. Now, even though I've worked hard to rebuild my life, survivorship comes with its own barriers. I'm back at work, but only part-time due to consistent pain. That means I can't apply for promotions, my career is stalled, and I'll never regain the earning potential I lost because of cancer. I had at least 20 years left of my career, and now I can't even move up the ladder. I am grateful to be working, but it's hard knowing that the long-term impacts of cancer are still shaping my opportunities. This is the reality for many of us. Cancer doesn't just affect our bodies, it affects our relationships, stability, income, childcare, identity, and the everyday logistics of being human. It exposes gaps in our system, gaps that often make people feel punished for getting sick. I'm sharing my story because these challenges are fixable. With better caregiving supports, more flexible employment policies, earlier diagnosis, and recognition of how survivorship affects long-term career and financial health, we can make the next person's journey lighter. Thanks for listening and making space for stories like mine. I'll hand it back to you, Stephen.
Thanks for walking us through your experience, Chantel, and really grounding this conversation in so many of the narratives that we were talking about at a national level, what it looks like at the individual patient level. Balancing your support network, the impact on your caregivers, return to work and unpaid time off are certainly themes we'll hear throughout the discussion. I'd like to jump right over to Meg and then Mary from a practitioner perspective on all of this. And I'd like you both to answer this same question. What do you see in your practices with respect to the financial burden of cancer on younger patients and families? And from a practitioner perspective, where are the gaps in the system?
Um, I guess I can go first, for sure. So yes, as Chantal was saying, it's a big thing about work. Employment is quite difficult. Of course, if you don't have a place that has an insurance benefits package or program, then you don't get insurance. You don't have that financial support. If you don't have a partner, then perhaps maybe you're moving in with your parents again, or maybe you're looking for a different job. Sometimes it can even be that younger people, like in their 20s, let's say, are in school, and what they might be doing. They want to go to classes. They don't want to miss classes, or maybe they have to take part-time classes. Again, here in Manitoba, there is like Manitoba Student Aid that can be quite helpful for people who are in school. But again, it's like trying to, again, like as Chantal said, this can be longer then. You're in school for longer if you can only take part-time classes. And maybe you had a plan to work and take classes at the same time. Well, it's going to have to be one or the other right now. So we see some of those gaps in like being able to provide financially for folks who are younger. And then that's like where we come in as a psychosocial oncology clinician, how we help in like that emotional support. Of course, we're like the place that does that. But there's also then looking to various charities, various places that we can try and reach out and piecemeal together something that can offload some of the smaller costs of life so that people can save money to pay like the bigger costs like rent or mortgage or groceries, or not groceries. We try to get more like grocery gift cards, things like that. But again, these things are not really long term.
I can certainly say that I've worked in Ontario and now currently in Halifax. And the one thing that remains true is that most people that are young adults tend to be diagnosed later, meaning a more advanced stage. And that puts them in a precarious position because it means often intensive treatment. They're not feeling well right from the get-go. And it's totally disruptive. And if someone actually has a job that's full-time, that's not normally the case. It's normally people are patching together part-time work based on our current economic situation. So not many people have benefits. Most people have precarious housing. And they're already precarious before this diagnosis, whether they're on the younger age or like in their later 30s, say. That's kind of across the board. So in that situation, like I was very shocked to hear the $30,000 because I've seen upwards of $80,000 in that first year. Because if a person has children and they do not have any other people able to help look after, then that becomes a big expense. If they're in a couple, one couple's not working anymore. And it just becomes very tenuous, precarious for food, for paying for the roof over their head, and trying to figure out cost because most people don't live close to a center. And getting to the center, staying at a center becomes a big challenge as well because they need to get back for a number of reasons. So it's very expensive, and most people don't keep their job. In my experience, it's very a small number that would be still gainfully employed at the end of treatment. Most jobs try to be helpful, but some people based on their age are just not even in their probation period when they're starting a job, and then immediately it gets taken away. Or people are on treatment and have to extend treatment, and then there's no job left for them. So I do think that it's an incredible challenge for many people to be diagnosed when they're between if you go for the 16 to 40 age bracket, if people are school age and they're lucky enough to be at home, they may have that as a situation, but that doesn't tend to be the majority of people that are diagnosed. And then if they're already in their own independent circumstances, that shifts and it becomes more precarious. So it's incredibly financially difficult. And I know you previously started to talk about fertility in the last chat. I'm not going to speak to that other than to say that adds on a whole different expense in that population, because already at baseline, you may be looking at 10,000, but then it goes up. So, and that's money that people just don't have sitting in their bank account, 40 and under for the most part. So all of it becomes very challenging. If you said, what are the gaps? I worked in a great place that had excellent resources, and that meant there was someone that was working in a school work transition role, super helpful. Also, someone that was working to try to assess neuropsychology needs, like, do you have this late effect from chemo where you're just not processing the same? What does that mean for your work? Do they work with the school or your workplace? So that role is vital, but it's not across Canada. Health psychology in every program, if there is a program, is not across Canada. Social work, maybe patch meal, and not necessarily available for all the needs, because financial is one, but there's also all the other mental health things that are equally important that may not be accessible across the board. Another thing that is missing in terms of a gap are providers. There are a speckle of AYA specific survivorship clinics across Canada, but that is not a uniform thing. I'm trying to advocate for one in the Maritimes. There is nothing in New Brunswick, for example. There's many provinces that just don't have one, but the need is there. And when I talk to people, they talk about the need, and the need is real. They need people to know why their treatment is slightly different, the advanced stage that they're diagnosed with, because that creates mistrust among the providers they've had before. Why did you just delay? Was it because I was young? Why didn't you take me seriously? Like, there's a big impact to be diagnosed and then still be in a system that doesn't feel supportive. So I think we need to make major changes and then look at places that have set up AYA clinics, which is like in Australia, in the UK, like they exist, and we need to take it seriously across Canada. So those are some of my thoughts on gaps.
Thanks so much for sharing that, Mary. I want to bring in Shannon for a personal financial planner perspective on all of this. But before I do, Meg, you touched on something that I just want to follow up on to make sure we get your perspective, because I think it's important, and that was around lost time. I'd like to follow up a little bit on the administrative burden that goes hand in hand with the financial burden in applying for supports, applying for insurance benefits, things like that. Is that something you see in practice? That lost time that goes hand in hand with those out-of-pocket costs?
Oh, absolutely. Like in terms of like completing forms or trying to fill out things or trying to even get an appointment to come and see like a social worker or to see me as a counselor. So I do both. Like I counsel people as they're going through treatment, also after treatment, or if they've lost somebody to cancer. And then I also try to find resource finding. And again, like where I live and where I practice in Manitoba, it's very piecemeal. So sometimes it's just having to fill out this information or having to fill out these paperwork, or even if they qualify for certain financial help. You're very right. That takes a lot. Also, when we think about like folks who are in school, what are they losing out? Are they losing out on a few years? Are they losing out on the furtherment of their career that they really wanted to start? Right? How do we regain those costs, or how do we regain some of that lost time? And you can't regain that time. The best thing that we have, or that I do in my practice, is to help people learn how we can accept these things, acknowledge these things, and then what do we want to do like moving forward in life, and what are the things that we want to change. And perhaps it's like Chantel in joining the AYA group and being an advocate. Kind of like that.
Awesome. Thank you for that. Shannon, I'm really excited to invite you to the discussion to talk and hear from a personal finance perspective. What practical strategies can help individuals navigate the sudden income disruptions and unexpected costs during a major health event? And how can we maintain financial stability while balancing treatment or caregiving responsibilities?
Yeah, it's really hard. And a lot of what everyone has been saying so far, especially with people under 40, that they're not necessarily in their peak career yet. Maybe they don't have a house or mortgage they could refinance. There's a lot of there's more limited options. Maybe they're in the gig economy. Maybe they don't have access to EI. So I think that it is a real challenge. And so the first thing, and we've already heard some people on this, is to try to tap into as many income sources as possible, even though it might be administratively difficult. At the end of the day, personal finance is what's coming in and what's going out. It doesn't mean it's easy. I wouldn't have a job if it was, but that's what it is. So you have to look at both things. What can I control when everything else is out of my control? So can I apply for any other income sources? What are they? In all of those, government programs, nonprofit programs, all those resources. And that can be daunting in itself, but often I find the income support might have, or the income programs might have more support from nonprofit communities and whatnot, whereas the actual where it goes after is often just on the person themselves because it's your personal finances. It's what you do at home. So if you can reach out to others to help you with the money in to try to stabilize that way, and then it's really up to what your personal finances are at that point. So one of the first things that I suggest during a crisis is making something that I call a micro timeline. So when we start to try to plan our finances during periods of complete uncertainty, it can be overwhelming and devastating to think about what's coming or what would happen down the road. So just focus on the next 4 weeks. What's happening for the next 4 weeks at a time. And then when you reach the end of the next 4 weeks, what's happening for the next 4 weeks? What's coming in and what has to go out over the next 4 weeks? And as much as I know that part of personal finance is always sort of keeping that broad stroke of that big picture. But when you're in a crisis, that can actually make it overwhelming and feel hopeless. So it's not, but we just have to focus on what we can control. And it's a lot easier to predict our life in the next 4 weeks than it is the next 4 months when you're dealing with something like a new diagnosis and a health crisis. So trying to focus on those micro timelines. This goes without saying. I think everyone would say, duh, Shannon, but I'm going to say it anyways. When you're looking at, okay, what's happening over the next 4 weeks? Reducing out anything that can go, right? Because you're about to have you may have just had an income reduction. So we're dealing with that, number one. Number two, looking at your money as in different buckets. So what has to happen? What's the non-negotiables? Because those are coming out of your bank account, like whether you like it or not, things like rent, your mortgage payment, insurance payments, anything like that. And really isolating and looking at each one of these fixed expenses and seeing if there's an opportunity to negotiate or if there's a program within your financial institution that can help you take a pause, take a break. So some mortgages, for example, if you have a cancer diagnosis, you'd be able to put a pause on the payment for a few months. Great. Maybe not forever, but we're focusing on the next 4 weeks. Like, cool. That's next month use problem, right? Like, let's do that right now. So any of those opportunities, credit card companies, anything like that, insurance brokers, the worst case scenario is no. And again, this puts a lot of work on someone who's in a crisis. But if you can have people in your life do other like to help in any other way, so you can do these really important things, having a pause or hitting the pause button on any of those fixed expenses is hugely beneficial to just save that money. So that would be the first thing I would do, the bucket of fixed expenses and what's optional there, because those are the hardest ones to get options on. The next bucket that you'd look at is probably if you're in a position where you're able to save before, maybe you have something going to RSPs, maybe you have something going to TFSAs, permission to pause, permission to stop. Just stop it. It's okay. That's okay. If this is a 12-month period or an 18-month period of your life, that is not going to make or break your retirement in the same way that spiraling debt or something like that could. And the long-term impacts of your financial confidence is also something that's very important. So feeling in control is like really important in this moment in time. So I'm not saying stop saving, but if you can't afford to keep saving, I'm giving permission to say that's fine. You just pause it. We're not stopping forever. We're just pausing for the next 4 weeks, and that's okay. We'll revisit next month and see what's up. So that frees up that cash flow. And then I think if you're lucky enough to have a home and you have a mortgage, if there's a refinance that would be possible, sometimes that can free up a lot of cash flow if you're in a position where maybe you were close to renewal and it wouldn't be that expensive. So looking at talking to your mortgage person and seeing if there's anything possible there to free up cash flow. And then also looking at your assets and saying, okay, if I do need to start dipping into savings, where am I taking it from? And so is there emergency savings? Again, really hard for people to have emergency savings these days. So that's an ideal scenario if you have emergency savings, or if you had a critical illness payout or something like that, budgeting budgeting that out. And all that to say that once you've exhausted all of that, you say, okay, I'm not going to spend money on the things I usually spend money for to sort of free up expenses for this. I'm looking all the things, the bucket of things I have to pay, whether I like it or not. I've gone through systematically and tried to get a pause on each single one of those things. I've paused any sort of automatic savings I've got, canceled any subscriptions I don't need. I've gone through everything, and I'm still in a situation where there's just not the income reduction combined with the increased unexpected expenses, which we've already covered many of them, parking, travel, special diets. This is something I see a lot of too, where if you want to eat a certain way after a diagnosis to try to help your body with healing, that is very expensive, right? And so, extra taxi rides and Ubers and all this kind of thing. So if your income is still not in that situation, you might be facing a moment in time where maybe the first few months is there's EI coming in or something like that, and then and there's disability, but it's just not necessarily enough. You might be looking at, okay, do I go into debt, or do I like live off my savings? And this is a dire situation for any person, in the sense that it is not fun to go through that. And I think that's when sort of that a lot of what everyone's talking about here, where you could sit down with a financial person who can map out like the pros and cons. And I say that to provide hope. So sometimes if you were to dip into savings, you might think that that is like so bad that everything is going to topple over, but maybe it's actually okay. And it's not actually, there's ways that we can make that up on the other side of this in a way that's sustainable and realistic. And then it can provide you with those guardrails around, okay, up to this, like I call it like a controlled crisis burn. So it's like, cool, you need to take on some debt. Let's do it in a really controlled way that feels like you're in the driver's seat, that you understand what's happening. It's every month I'm supposed to go $500 or $1,000 into debt. That's on purpose. And on the other side of this, I know exactly what it would be, and I know exactly what I'm going to do to tackle it when I'm through, in a really realistic and sustainable way. And so that can provide, I think the word I'm looking for is like peace of mind, that even though it feels like your finances are on fire because everything is the opposite of what you think you're supposed to be doing or what you were doing even like 2 months ago, it doesn't mean that all is lost in the long term, even though it is very much a challenge, and everything that everyone's talking about is absolutely real. But just kind of surviving. You're in survival mode, right? And it's an emergency. And so the normal rules don't apply, and you just have to get through with as little debt as possible. And that is the goal. Taking on as little debt as possible and dipping into any savings you've got as little as possible, even though you might have to do it. If you're going to do it on a controlled way so that you feel like you're in the driver's seat and you know where that sort of limit is. And I think that's where making a bit of a plan can help, but really focusing on those next 4 weeks. And that would be, that's the most that's in your control, right? Is where your money goes is in your control, and that can actually be relieving. So those are my tips for the micro timeline.
No, those are fantastic and really grounded. So control what you can control, focus on chunks of time, so that first 4 weeks, and then sort of reach for any programs that might be available to offer some support. What I really appreciated about what you were walking us through is bringing together that perspective of, there are specific costs related to your cancer treatment, but all of those other costs, debt, mortgage, rent, automotive payments, school payments, things like that, those don't go away just because you're diagnosed. What I found really interesting is your piece around, some mortgages could be paused, payments, things like that. So just a follow-up question on all this, if you had to design sort of one non-governmental program to support people, like based on your experience helping people navigate this, what is one support that is very valued that you sort of go to whenever it's available?
I think the pausing of any debt payments is one that those are private corporations that are doing those. Obviously, they're not government funded. That's very helpful for people. So anything that can give a break on those. If there was, those are the supports that I would say would be the most helpful and often the biggest bang for their buck, right? Is like an immediate stop of any sort of bill that you have to pay would be the number one thing that I wish was across the board mandatory, like for any rent, for landlords, and for anybody who has it, like for lenders. I think that is really something that would be important important that the housing piece would be secure, even if it was just for a very short period of time, just to give someone some breathing space when they're going through a crisis.
Excellent. Thank you for that. I'd like to turn back to Chantel now. And, Chantel, hearing all of this, the practitioner perspective, the financial perspective, and given your direct experience and your leadership role at AYA Can, what resources, supports, or strategies do you find useful that patients could take advantage of? And what policy strategies could be considered to close some of the gaps that we're hearing about today?
Thanks, Stephen. That's a great question. I think really what's difficult is a lot of newcomers to Canada, is from what I've seen. People who move here, to start a new life, to continue on, and then unfortunately get diagnosed with cancer, or in the family, and they have a lot of struggles meeting those basic needs, the rent and everything else, as they need to, especially families with multiple children, that can be really difficult for them to be able to meet the childcare costs or transportation costs getting to the hospital, and what to do with their children while they're going through cancer is often really difficult. So definitely that, as well as fatigue. Like, a lot of patients go through a lot of fatigue. So even as Shannon's talking about, hitting pause on all these payments, if you don't have a spouse or a partner to be able to assist with things like that, like I know myself, just really fatigued and overwhelmed with a lot of things, and just had difficulty even applying for the benefits that I fortunately had, but just having difficulty filling out the applications and things like that. And that's where people like Meg would come in handy, is to maybe help with filling out forms and things like that. Yeah, I think that's the biggest ones.
That's great. Thank you for sharing. We have plenty of time, which is excellent. So we could turn to some questions from the audience. So the first question, with the work done by CCS on the cost of cancer earlier this year, is there any consideration to conduct further sub-analysis or further research into how the costs may differ for younger patients? As Mary suggested, these costs may be significantly greater for early onset cancer patients. So I'll start on this one. Really appreciate this question, and we're always looking to expand on the work and rigor that we've done on our sort of large national focus areas when we do the Canadian Cancer Statistics work. I will say, when we get into sub-analysis, some things we run into are lack of data and lack of data access in these areas. When we did the cost of cancer report in particular, we were asked about provincial breakdowns and how this varies by province, but we ran into data limitations on, being able to go that deep with the information that's available. So, as a Canadian cancer ecosystem, one of the things we're calling for at CCS is to, have a cancer data strategy across Canada that will allow us to collect better data, to have data be transferable around provinces, and help with these sort of sub-analyses that you're talking about. That said, to the panelists, we're always looking for opportunities to partner, to dig deeper with other organizations. Are you aware of any work that really highlights the financial cost of cancer to these populations that we're talking about today?
I'm not sure about recent work. There's been work done for the past 10 years to try and understand in different population settings, like how expensive is cancer. But to answer that question about recent, no. I think another thing to consider if you're trying to advocate for something helpful is the dispensing fees that most pharmacies disperse. If you're trying to pay rent and food, then most people will forgo medication that's not given to them at the hospital. So that if there was a way to try and get people to be able to take their therapy that wasn't provided in the hospital, then I think we should look at what are the barriers, which would be financial, and that would be trying to pick it up. Like, the cheapest place to pick up a prescription is either Costco or Walmart based on a reduced dispensing fee. So I think we have to look at how can we help people when they're outside of the hospital to kind of maintain therapy, because not all therapy is given in the hospital. Oftentimes there's a cost when they leave the hospital.
That's such a great point, Mary. And adherence to treatment and the impact of cost is something we haven't touched on yet, but it's very real. There's a 2024 report that we looked at that essentially found families with incomes of less than $50,000 for a family income, about 20% of lower income families would forego medications that were prescribed to them as part of the cancer treatment. So the impact on cost and adherence to treatment is very real as well, along with navigating all of the challenges that we're talking about today. Another question from the audience: do you feel that specialized EAOC clinics would help younger patients to address financial issues? So it's to any panelist. Mary, did you want to start?
Just give me what does the long form of that short form mean? EOAC means
Early age onset.
Oh, I like AYA. I apologize. I actually think it would be advantageous to develop AYA clinics across Canada, 100%. But because you need providers that are comfortable working with young adults, and then you need all the helpful specialty people like a psychosocial support, like someone that can look at school work transition, and you need them to work together. You also need in that same hub, it could be like a referral system, someone that's very comfortable talking about fertility and treatment effects, because that's what people need when they get in the gate, is foundational information that they can take back to their provider. So I actually think it could be set up. You just need in different provinces and different settings, like a hub of expertise that people could meet with virtually, in person to access. And then people can actually start when they're diagnosed with some helpful insight to take with them. Because I feel that people get a diagnosis, but without that helpful link.
Mary, can I just make a comment? So you're advocating for having like front loading, like basically once AYA patients are into like the machine of cancer, then have all that information up front. Is that kind of like what you feel like is helpful?
No. When they get a diagnosis, there should be access to that after a diagnosis. Like front loading without a diagnosis wouldn't necessarily help anyone.
Yeah.
But to have that access, because many people are diagnosed and get no access thereafter.
Yes.
So
Yeah.
I think it would be helpful to have one and then the other. And sorry for not knowing the abbreviation.
No, I didn't know it either. In Manitoba, we call it AYA, so it could be just a different provincial acronyms or usage, but
Excellent, and noted on the abbreviations. We're getting a lot of audience questions come in, which is amazing. It really shows the excitement around this conversation. So to the panel, what common misunderstandings do you see around disability benefits, income supports, and employer policies? And how can younger patients better advocate for what they're entitled to? Who would like to start? So I could jump in to
Yeah, you jump in, and then I have something to say about outside of employers with disability and stuff like that. So you go ahead.
Oh, perfect. Thanks, Shannon. Sorry, I didn't see your hand. So one thing around employer policies that we've learned since doing sort of cost of cancer work, a few years ago, a number of patient organizations advocated for an extension of the EI sickness benefit from 15 weeks to 26 weeks. So that you had income closer to the duration of treatment for some of the more common cancers. Certainly more work that could be done there, but more income protection and support as you go through a cancer diagnosis. That was a change to a federal policy. So only federally regulated workplaces were sort of impacted by the job protection that comes along with that. So that actually left a policy gap in provinces where you had access to federal income protection, but your job, which is might be in a provincially regulated workplace, which is most jobs, didn't have any direct protection tied to the EI sickness benefit. So you could be in a position where you're drawing from EI for 26 weeks to have income during your cancer treatment, but the job that you're taking time off work from is actually unprotected. So we've been sort of working with patient organizations and patients across Canada to advocate for job protected leave in provinces and territories, because for at least 26 weeks. Because you could have been left in a situation where if you were let go because you took that time off work, you would have had to either make a human rights tribunal complaint or like labor relations complaint. So this would provide upfront protection to your employment as you're drawing from that EI sickness benefit. And to date, since the EI sickness benefit has been increased, we've had, I believe, 8 provinces sign on to at least 26 weeks of job protected leave. So we have 2 more to go, but that's certainly an important piece around employer policies and government mandated employer policies. That's a bit of a gap. But Shannon, I want to turn it over to you.
Well, I was just going to build on that, actually. It's good that you went first. Is that I see a lot of people who are in the gig economy and don't necessarily pay into EI because they're self-employed and they don't, so that wouldn't even be an option. So having an employer, it isn't really there. And maybe they didn't, and if you want to apply for self-employment EI, you have to do it 12 months in advance. You have to be like psychic and be like, I think I'm gonna need that later. So I get the question a lot as to whether or not self-employed people should be paying into EI special benefits. And I think it's a really custom answer. So I wouldn't say yes or no. I've seen it work and I've seen it not work. I think it's something you should get some custom advice on. But what I wanted to say is that within an if you're within an employer position, the short-term disability and long-term disability benefit, like the whatever packages that they have it, I think that most employers should be able to offer some sort of benefit that way, because I really have seen disability, like income replacement, be a lifesaver for so many people that have had a critical illness, and opposed to those who don't. And so again, we're talking about self-employed people who may not have access to a short-term disability, long-term disability. And so that's another thing where I feel like there's just a gap with young people. Sometimes income replacement, like life insurance, gets the big, everyone's like, lock it in when you're young. But I don't know that we're talking a lot about income replacement, critical illness, and disability insurance. I don't sell that stuff, by the way, so this is completely unbiased. And I think that those are gaps that while people are young, that if they were thinking about, I'm a self-employed person and that's something that I absolutely require to have in my life, could act a little bit of a barrier between like when you're faced with a health crisis, the financial fallout from that, if you have a little bit of that disability as well. So I just think there's a gap there with the self-employed sort of gig economy as well.
Awesome. Thank you for that. Chantel, can I ask you to just expand on the last part of this question? So how can younger patients better advocate for what they're entitled to? It's around self-advocacy, and I'd be interested to hear, how did you advocate for yourself?
Well, mostly it was with doctors. Luckily, again, I had insurance through work. I do work for the like a unionized position, so I was able to access long-term disability benefits. I did have issues when it came to COVID, and they cut me off and everything like that. So I did have a lot of issues with the long-term disability insurance. So I tend not to speak out too much about it because I've heard horror stories that they are watching your social media accounts, that they are following you and seeing, if you're working, if you're not working. So a lot of people are scared to do advocacy work, or scared to do different types of volunteer roles, because they don't want to have their insurance benefits cut off, or, different things like that. So it's a little bit of a tricky subject, definitely. But as far as, policy, I think people should have benefits. I think the EI caregiver benefit is not, you're expected to die within 6 months. I think that's a little harsh. I'm going through treatment. I don't know if I'm going to die within 6 months. Nobody has a crystal ball. No doctor will give you that type of diagnosis, or, end of life diagnosis at this age, hopefully, unless it's really, really serious. But you still, like going through surgery, I still needed help. I still needed help taking care of my son and with the daily tasks, around the house. So I think, young people should be able to have access to benefits and insurance. I know in our university, when I was in the university, we had to get a group life insurance policy. It was kind of required as a student, unless you were covered under your patients. So I think that's something that's, really a great thing for young people who aren't expecting to get sick, hopefully, and should be maybe a little more common. I like what Shannon said too about, if you're self-employed, then you don't think about these insurance things. But yeah, unfortunately, young people need to start thinking about these things.
That's great. And really kicks off the next question from the audience. Do you believe that patient advocacy groups can help to improve the issues that patients face as a result of the financial burden? And Chantel, just building on your point as well, making sure patients feel safe in partnering in that advocacy, as you say, if there are concerns around any pushback from employers or things like that, and taking part in advocacy.
Yeah, we haven't delved into that as far as AY can. Like in our organization, we haven't delved into changing policy on employment issues. More focused right now on supporting patients becoming advocates and helping with that. But definitely, I think that's something that needs to happen, just to help, young people get the support that they need. And obviously, this is an issue that is important, and not losing your sense of financial freedom is as you go forward in life, because of a diagnosis when you're a young person. I think that's a huge thing, a huge piece of this gap that we're identifying.
And I think from this conversation, we're learning that these issues are shared by so many. And at the risk of being called an optimist, I do feel that our system of government works when people get involved. So to that first point, do you believe patient advocacy groups can help to improve the issues that patients face as a result of the financial burden? Absolutely, yes. Right now, we're running a campaign on the cost of cancer. We have over or nearly 100,000 Canadians have signed on. And really, the point of this is to build collective action. So, have this be patient-led, have the advocacy be patient-driven, so that we're asking the Canadian public and people impacted by cancer to do something in their power. That could simply be sign a petition. We then take those petitions and work with patient leaders and patient advocates to deliver them to their locally elected official. So sort of ask their locally elected official to do something in their power, and that might be a letter to the Minister of Health. So that by the time that we get in front of the Minister of Health with a list of asks related to reducing the cost of cancer care, we could say, Minister, 100,000 Canadians have signed on to this initiative, and 60% of your colleagues have sent you letters calling for change in these areas as well. Will you help us? So we're sort of building that coalition and that advocacy even before we're in the room with the person that could really make that change. And patient partners are such a key part of this. To bring the lived experience of patients, particularly in early onset, but also to localize what we're hearing, because the cost of cancer issues that I face in Ajax, Ontario, are very different from the transportation and travel costs that someone might be facing in Sault Ste. Marie, Ontario. So we need to sort of localize those perspectives, and that's where patient partners, along with providing the lived experience of facing cancer, really come in support these larger campaigns with patient advocacy groups. So we could go to our next question. Beyond the obvious out-of-pocket costs and expenses, what invisible costs do you see disproportionately affecting younger Canadian patients? And how should financial navigators counsel patients to anticipate and plan for these less visible but highly impactful costs? So Shannon, did you want to start?
Yeah, I have a couple of things to say on that. So there are, besides the day-to-day next 4 weeks, the one big one that I think is sneaky that I don't know that anyone is looking at, and this really depends on how long the time out of the workforce goes, is that in Canada, paying into CPP is something that you do, whether you're self-employed or employed through an employer. And up into a certain maximum, approximately $73,000 you're paying. And so what I mean by that is if your income is reduced and you're not able to pay into CPP for a length of time, it could actually potentially impact your long-term pensions from the government, depending on that. So I wouldn't, how it works too is like it gives you 7 years that you don't need to contribute as far as like your whole history, if you look at from your 18 to 65 in Canada. So maybe not that year out, but where I see it impacting it, or the sort of invisible cost, is if you have a large income disruption during your where you're trying to build your career and you're out, and then you're not ever able to sort of join back in on the original trajectory, where your income lands after that could be lower, which means your contributions to CPP are lower, which means that later on down the road, that's a retirement benefit that's been reduced for you. So that's one of the places that I think that it sort of like is silent and we don't really think about it until much, much later, is the percentage of CPP that's being reduced, self-employed or employed. And the other place that I think is sort of hidden is along the same vein, which is the ability, like not only the original income disruption that happens, but the ongoing income disruption that might happen later on. So are you ever able to work at the same cadence or pace? Where are you at in that job? And I think that that's really important, because one of the things when I talk to young people not dealing with a health crisis is I constantly say, and I say this to adults too, your future income is your biggest asset, right? And so if that asset is threatened, then that is going to impact all the other decisions down the road. So I think really, as we're talking about gaps, it's like joining back into the labor force and trying to, with either new training or something to help get that income back up to where it could be, so that we sort of get back on the track. I think that would be really important. But I think that's one of the big silent things that doesn't get calculated in, and it means that it falls again to the person to save more on their end with less income potentially. So just another piece.
What I've seen in practice is that people that are diagnosed as young adults end up having in their 30s almost like a medical frailty that makes it harder for them to work physically. So if they can get back to work, it's with a reduced income right from the get-go, which goes against what you're saying, that they need to kind of increase. I haven't seen everyone able to do that. They're researching medical frailty now to try and understand the impact in young adults or people in their 30s and 40s. But it seems to be that there's some sort of advanced frailty when people are treated as a young adult. So I'll just put that out there, that the research is now focusing on that, and that's what they're identifying.
Yeah, I think that's great. That is actually my point, is that it could impact it for life. And so if there was any sort of policy gap to help someone earn something, even if they can't work in the same clip that they used to be able to, that would really help.
I think those are great points. I mean, so much of this conversation was, focused around the first year of treatment or the first 4 weeks and strategies to, get through those first 4 weeks of treatment. But that longer term planning and impact on both your health and the costs that come with that, but also your income and employment, it is really one of those invisible costs that the question was getting at. For me, something I found very striking in doing this work is that 42% of Canadians that worry they'd miss an opportunity for career advancement because of their cancer diagnosis, and that would be lost income in perpetuity throughout your career. So certainly invisible cost to talk about. Another question from the audience: how do you navigate long-term disability insurers who are asking if you want to take early retirement instead of continuing on long-term disability? Shannon, I'm going to turn to you.
Yeah, I'm pausing because I'm not entirely sure how to answer that, and I don't want to say something incorrect, like not incorrectly, but just like false hope or false. I think the question is wise in the sense that how you answer your disability forms matters. I think that that's an important thing to note. And so that would be something that you might want to get some custom advice off of the call on how to navigate that for yourself personally. Because I do know that we want to make sure that we have insurance and we're not saying things in a certain way that would be false, but we also just want to make sure that we're like, if you have a diagnosis, that obviously it's going to impact things. So I just think that might be an opportunity to get some customized advice, I would say.
Yeah, no, I think that's a very fair response. I mean, so much of this depends on your personal circumstances and what's available to you. When we talk about solutions to the cost of cancer care, there's some big pieces around if you're in Ontario, universal access to take-home cancer drugs, things like that, transportation, travel and transportation, large bucket items. We heard from the last panel a lot about the cost of oncofertility and treatments in that sense. But it really is, there's not one silver bullet we're talking about here. When we're talking about the solve for the cost of cancer, we're talking about 1,000 different solutions. So we have about 5 minutes left as a panel. I'd be really interested in hearing from each panelist about if you could solve one thing as it relates to the cost of cancer, what would that be? Who wants to start?
I can jump in. For me, one of my biggest thing would be clinical trials and the cost of drugs that are like, say, single patient trials. The cost, you know, there's a lot of new research out there that immunotherapy drugs or clinical trial drugs would be really beneficial to a lot of patients, especially with unique types of cancer, rare types of cancer that we see a lot in young adults. But those drugs are not covered. And to me, having better access to coverage for those patients would be huge. I think there's so many people that are saying the one pill a month will cost them $10,000. That will easily bankrupt you or, you know, take your life savings away. And they just really want to stay alive. So people are willing to do it because we're young, we have a lot of time left. You know, you want to be here for your family or have a family. But yeah, you can't, you know, people shouldn't have to choose if it's life-saving treatment or going into debt. So I think that that needs to be addressed and certainly helped. That would be a huge, huge saver.
It's an excellent point. So looking at clinical trials more as standard of care in cancer care versus a nice to have or an add-on, which is how we currently look at them today.
And they can add in money for parking and for other things as well, because they have enough money when they set it up in other circumstances that they could be more inclusive of the costs. And in terms of the technology, like an iPad to do a virtual visit, like there's lots of things that they can do in 2025 to make it accessible for an AYA person. I would agree with you. If I could wave my magic wand, I would ask that everyone have access to someone that is knowledgeable about the experience. And there's a team approach after a diagnosis that people across Canada could meet with people virtually or in person to try and get an overall clinical assessment. And then they can get access to things that are super helpful within their province. Like, how do you access fertility in your province? What's covered? How do you try to come across medication coverage? How do you come across other coverage costs for one-time rent, for one-time food, like what is available? And then it should also be like, how do you get back to work? And what kind of rehab do you need? Like, there should be a comprehensive list of people that you can access to get back on track if that's possible based on your diagnosis and treatment.
Yeah, no, that's a fantastic addition. I think everyone's ears perked up as well, Mary, when you said the cost of parking, which certainly we hear about often. Meg or Shannon, anything to add before we close things off?
Not much. I really love that, Mary. I think that having access to people who can help patients find those resources, or even when we're talking about like after, like survivorship, what does survivorship mean? And Chantel, you are in this spot now, but like, what does that mean for your life? You've experienced this huge life-changing event. What does it mean for your job? What does that mean for who you are as a person, or your family, or your children? What does that mean for longevity of your life? Is there going to be a recurrence? Like, there are so many things that I feel like sometimes, as Mary said, once they get in, you're just kind of going through treatment, you're going through all of these, showing up to every appointment, doing all of that. But what is actually can you access so that this long-term survivorship, or what information can you access so that you have maybe survivorship? I think that if access to information is incredible, and we can only do so much. There's not really even a comprehensive list for people like me.
No, those are great points. We are at time, but I know these conversations are going to continue offline and with the audience. I really want to thank our panelists for all of the insightful perspectives that you brought today, and the audience for the very detailed and dedicated questions that were provided. I'll now hand things back to Cassandra.
Thank you so much. You know, this is a massive unmet need, the financial burden. And, you know, we talked about it in our survey results this morning. We really saw that across tumor types across the country. Stephen, I know CCS has done a lot of great work in this realm. So thank you to our panelists and Chantel, especially for sharing some of her lived experience through this session today. I will take a quick opportunity to address the acronym. So we've kind of touched on this throughout the day or 2 days for new viewers coming in. So the Symposia series and Grant's mandate is focused on adults who are diagnosed under the age of 50. And certainly that 40 to 49 age group, they do make up a significant portion of this subpopulation. However, a lot of programming in Canada, including some of the programs represented by our panelists on this session, are focused on the smaller subset of the AYA population. So we've been talking about both populations throughout this symposia series. But yeah, EAOC is referring to early age onset cancer, so those diagnosed from 18 to 49. And then the AYA is those diagnosed in adolescence and earlier young adulthood, usually to the age of 39. Thank you for the opportunity for me to jump in there and remind our audience of the various acronyms. So as we head into our last health break, we are sharing a special video which was produced for Biomarkers Awareness Day, which was just on November 13th. And this video will be followed by featured patient and clinician video testimonials. We will see you back at 3 p.m. Eastern Time as we explore the cancer experience through the lens of individuals from marginalized populations. Thank you so much.